And the question we're going to ask in this panel is, how do we make this a long-term effort that's sustainable over time? Because the previous panel showed us how you can make quite big increases, but we're still not at the level we want to do it. And of course, we've got to keep that effort. As each new set of cohort of population ages, we've got to allow them to be able to be part of the system. So the efforts have to be sustained. So I'm going to just introduce who will be on our panel. We'll kick off with Dr. Dominika Novak-Mlakar, who is from the head of the colorectal cancer screening program from Slovenia, which, as we saw on the slides from Dr. Pizar, that it's really got extraordinary results. We're also then going to hear from experiences from Germany, Ireland, and Lithuania. Dr. Jürgen Reimann, the founder and chairman of Lebensblick Foundation for the Prevention of Colorectal Cancer in Germany. From Ireland, Professor Porrick McMathuna, the Professor of Medicine and Clinical Director for Bowel Screen in Ireland, and Professor Thomas Poškus, the Professor of Surgery at Vilnius University and a member of the Coordination Committee of the Colorectal Cancer Screening Program in that country. So let's start by hearing from Slovenia. How do you generate a large momentum to increase the numbers of people participating, but then make sure you can maintain that over time? Dr. Mlakar, the floor is yours.
Thank you for the introduction, and hello to everybody. And thank you, the organizers, that I have an opportunity to share with you Slovenian experience. Next slide, please. In 2009, Slovenia launched the National Colorectal Cancer Screening Program called Program Suite. It is a population-based program, nationally organized and centrally managed. The immunochemical fecal occult blood test is used as a screening test. Target population covers 600,000 people aged between 50 and 74 with compulsory health insurance. Before the population-based program was set up, only rare opportunistic screening was performed. Next slide, please. The program algorithm is designed as user-friendly and as simple as possible for all procedures that must be performed by the participants. Most procedures can be performed by participants at home. The significant part of communication with the target population is done by regular mail. Participants receive an invitation, and those who choose to participate return a letter with a written statement of participation to the program central unit. Test kits for samples collection are sent by mail from program central unit. Samples are returned by post to the central laboratory and analyzed the same day. All participants and their GPs received a test result. Participants with a positive test are referred to colonoscopy, and those with a negative test receive an invitation to screening in 2 years' time. Participants' responses are monitored, re-invitation and reminders are sent, and special attention is given to disabled people. Slovenian guidelines for early detection of colorectal cancer were published in a book in 2016 based on initial instruction for work. Next slide, please. All the participants who were crucial for the organization and implementation of the program were identified and included. A common language with the Health Insurance Institute of Slovenia and Ministry of Health was the basis for the secure funding of the program. Next slide, please. The Ministry of Health established the screening program, and the Health Insurance Institute provides financial resources. The National Institute of Public Health is the responsible authority for colorectal cancer screening. In the program central unit, in-house mailing services handles outgoing and incoming mails. In the central laboratory, all stool samples are analyzed. Call center is responsible for colonoscopy appointments, organization, and ordering. Once the patient has a positive test, a general practitioner is actively included in the preparation for colonoscopy. The physician assesses whether a patient is able to undergo colonoscopy, fills out a referral form for our procedure, and prescribes the colon cleansing drug. With ambassadors, these are patients who already participated in the program, are also involved and are important in promotional activities. Also, GP's teams are involved in the promotion of the program among various target population and also in the communication with non-responders. Next slide, please. Next slide. For the purpose of the program, the legal basis for the implementation and personal data handling were arranged over time. Financing of the program is not dependent on changes in the state budget, nor of the political situation in the country. Next slide, please. Monitoring the performance and outcomes are crucial in providing quality and safe services for screening participants. Quality indicators allow us to track individual screening providers. Thus, we have the opportunity for improvements in the delivery of health services, treatment of patients, and ensuring their rights and the best treatments outcomes. Improving the quality of work of colonoscopists and pathologists in the screening also means improvements in the work outside the screening in their daily work. Next slide, please. For the fourth screening round, 600,000 people are invited to the screening program. Up to the fifth screening round, 64% of the invitees responded that they want to be screened, and 60% were actually screened. 93% of those who has a positive test completed a colonoscopy. Quality indicators are used for monitoring the results of each screening round. Next slide, please. According to the Slovenian Cancer Registry, the incidence of colorectal cancer has been increasing since 1961. The majority of cases were diagnosed in advanced stage of the disease. Between 2005 and 2009, colorectal cancer was diagnosed in a localized stage in less than 15% of cases. Since 2011, immediately after the first screening round, the Slovenian Cancer Registry has recorded a decrease in colorectal cancer incidence at the national level. The incidence increased slightly in 2015 as we began to include people up to 74 years of age. The trend of reducing the number of newly diagnosed colorectal cancer is still ongoing. The removal of precancerous lesions during colonoscopies within the screening program has an important impact on the. Next slide, please. Prior to the implementation of the organized population screening, colorectal cancer was the second most frequently newly diagnosed cancer. After 4 screening rounds, colorectal cancer slipped to the 5th place in frequency. Next slide, please. According to the Slovenian Cancer Registry, the 5-year net survival of patients with detected colorectal cancer in screening is 30% better than that of cancer detected outside the screening program. For the group, 50 to 74 years of age. Up to 65% of cancer cases detected in the screening program were in an early stage, and further oncological treatment was not needed. Next slide, please. An organized national screening program is the best way for systematically early detection of colorectal cancer. However, enough people need to be involved in order to achieve the. When the SWIC program was being established in 2008, a communication strategy was designed. We examined the communication strategies of the screening program abroad and adopted some of the most successful examples to our cultural environment. We avoided threatening messages and tried to motivate and assist people in joining the program with various approaches. We not only focused on the target population, but also addressed the general public through communication activities, since digestion, excretion, and especially observing our own stool are still a taboo. If we want people to be more responsive to the screening program, we must first get them to talk more openly about the topic. Next slide, please. To approach individuals, we organize presentation events in the local area since the beginning of the program. At the events, the SWIC team is available to provide all the information. They raise public awareness on the topic and encourage dialogues on the subject, which is still a taboo. We have designed programs with toilet paper in collaboration with Slovenian company, which printed our logo and message on their most popular line of toilet paper. Programs have been advertising on buses in all major cities in Slovenia. We have made TV commercials, and every March we run awareness campaign with big blue ribbons that we place on the door of all our National Institute units. We send also smaller blue ribbons to NGOs, media, and politicians. We regularly post about the program on social media. We have also made a series of short videos with celebrities and ordinary people, encouraging population to participate in the screening program. Various materials and tools for different groups of people were developed. A leaflet with general information about the program, a short booklet with step-by-step instruction on how to participate in the program, cards with interesting and somewhat humorous but true facts about digestion, and also comics that illustrate all the steps one must take to successfully participate in the program. They are intended primarily for people with cognitive disabilities as well as others, as they are easy to understand. Next slide, please. The program achieved the set goals, and we try to be even better. And for the end, an example of good collaboration, namely Post of Slovenia is also aware of the importance of health prevention, and they dedicated a special postage stamp to Slovenian colorectal cancer screening. Thank you for your attention.
Thank you very much, and very interesting to see the range of public-facing activities that you did, from the postage stamp, sending out the ribbons, the videos, social media, the campaign with the toilet paper manufacturer, etc. So clearly you've done a big outreach to the general population, which would hopefully answer some of the questions we had from previous panels about parts of the population who are just not in contact with health systems, or generating a conversation to tackle the taboo. Let's now hear from other parts of Europe how you keep the momentum going and make an effort sustainable. Let's start with Germany, one of our biggest countries in Europe. Can I ask Dr. Jürgen Reimann to share his views in Germany? How have you managed to keep up the momentum and make it sustainable, these efforts on colorectal cancer screening? Dr. Heimann?
Could you make the camera on?
Yes, there you are.
Okay. Good morning, everybody. Thank you very much for the invitation. I just briefly would explain what is going on in Germany. We started in 2002 with a national screening program on an opportunistic basis, consisting of guaiac-based FOBT and the colonoscopy, beginning with 40 years of age, 50 to 50 years of FOBT once per year, with 55 having the choice between colonoscopy and continuation of FOBT then every 2 years. Colonoscopy could be repeated after 10 years when the first examination was inconspicuous. Examinations were paid by the health insurance companies. Colonoscopy was linked, or is linked, with strong quality requirement for the endoscopists, such as numbers needed to do per year, excellent equipment, hygienic standards, and others. Colonoscopies only are evaluated by the Central Institute of Ambulatory Healthcare in Germany per anno for every investigator. The acceptance of this initial screening was only moderate. We saw after 10 years that the participation rate with colonoscopy was about 20%, and with the FOBT not even much more. So in 2008, the German government started the National Cancer Plan, consisting of members of different organizations, from the health care situations to the scientific organizations, with the aim to enroll a survey about oncology in Germany. And I had the chance to be the chairman of the group for the further development of colorectal cancer screening. One of the major reasons was that the acceptance was only moderate, and we had to look for instruments to increase the acceptance of the screening program. So we recommended from this cancer plan strongly the change from the opportunistic screening to a nationwide population-based screening. And it took about 5 years more before it was implemented in Germany. It was still in 2019 when we started this program. Before we had changed in 2017 from the FOBT to the FIT test. It was a long and endless discussion, but finally it happened. What is now going on? We had from this National Cancer Plan a steering group, which is taking care every year, looking what can be achieved more, where we have to improve this system. In addition, the government has started a national decade against cancer, in which prevention does play a leading role. We have initially had a public awareness done mainly by foundations, by health insurance companies, not only by the government. And we have started together with other foundations, a colon cancer awareness month in March, where we are focusing and concentrating to inform the public about what is going on with colon cancer screening.
Excellent, thank you very much. So again, you've highlighted for us the range of different areas and how you discuss it, you take people forward, and then you create the momentum. So now let's turn to Ireland and let's hear some of the experience there. Ireland has, of course, recently been having quite a lot of focus on tackling inequalities and an all-Ireland health strategy with some focus on inequalities, young people, maternal health. Let's hear how they're doing on the area of bowel cancer screening. Can I invite Dr. Padraig McMathuna to please share the experience?
Thank you very much. Can you hear and see me?
We can. Excellent.
Again, once again, thanks again for the invitation to participate in this European format, and I think it is very timely. Again, just to give a brief background, like my German colleague, we started our bowel screen colorectal cancer program 8 years ago. We already had established cervical and breast cancer screening programs for women over many years. It's a FIT-based program. It was one of the first internationally, with a FIT-based converting to colonoscopy for positive FIT. We've run 3 rounds, and our age range is 60 to 69. We started on, the idea was to have it from mid-50s to mid-70s, but from an economic point of view, we started between 60 and 69. Our compliance uptake post-FIT is about 45%. It started at about 38, so gradually we're moving bit by bit upwards. Following invitation for colonoscopy, our compliance is about 80–85%, which isn't too bad. And we have 14 centers nationally. So geographically it's spread, and there's no focus or bias in terms of cities. We're getting about 50% polyp yield and about 5% cancer yield. It's entirely publicly funded, again, through our Department of Health. And so it was the first program to involve men, which I think is culturally important. And again, that got over one of the challenges in terms of the stoic Irish man, perhaps the European man, in going to see the doctor. But we're catching up in that regard. I think in terms of sustainability, again, I think that many of the features are common throughout many countries. The Irish Cancer Society have been one of our advocates. The publicity campaigns that are run through the media, again, are helping to target, again, individuals in this age group. Many people are getting, as they're getting to mid-60s, are retired, so they are focused on their health, and we're hoping that men in particular start to take this seriously. There's a lot of publicity about prostate cancer, lung cancer. Again, there's no formal screening program, but this is becoming embedded in the psyche of individuals in that age. As regards sustainability, again, the funding is ring-fenced for this program, and obviously involves the colonoscopists in the various centres together with the surgeons, and we have a CT colon facility for individuals who fail colonoscopy. We don't offer CT as an option on a menu, so it's used as a backup. And our pathologists again are obviously closely involved in terms of polyp surveillance. The challenges are, and we engage directly with our Department of Health and our minister. The Minister for Health is obviously a vital person, but I suspect it's the same in many countries. The Minister for Finance is the person who holds the purse strings. And by coincidence, where I work, he's our local member of Parliament, which doesn't do us any harm. I think the reality of a post-COVID world has moved the goalpost significantly, in the sense that we're taking it from a financial point of view. We're taking it that the European Central Bank is bailing out all the countries because of the financial crisis, and we're trying to maintain the cancer services, and within that the cancer screening services, intact. Now, to date, the lobbying has been effective, so it's not been compromised. And again, time will tell what will happen to the finances in the next 2 to 5 years when everybody has to start paying back this money. But we're focusing on maintaining and expanding our age range from below 60 and above 70. But again, that very much depends on the resources available for colonoscopy as opposed to FIT. It does bring, again, finally, I think the post-COVID world means that many of the European countries are sharing the same financial challenges across the health sector, across all the health sector. And so I think it does make sense in a forum like this to try and coordinate specific funding for cancer services, and within that, cancer screening services, including colorectal, as well as the other breast and cervix, which are sex specific. So if this meeting or this forum can generate a unified approach, and again, hopefully, I didn't want to mention Brexit because Stephen Halloran is here from the UK, but hopefully from a medical point of view, a deal is done, and that the UK can maintain the clinical the partnership with their European colleagues. But I think it will need a coordinated European approach to help this develop and sustain the program.
Excellent, thank you very much. And now let's invite the last of our panelists to give us the view from Lithuania, over in the Baltics. So can I ask Professor Tomas Poskus, tell us how you've created some long-term efforts there to increase participation?
Hello, can you hear me?
Yes, we can, and we can see you.
Yes, thank you. So colorectal cancer screening started in 2009 in Lithuania, and Lithuania is a small country, it's about 3 million people. And it started initially as a pilot project and then moved to the countrywide spread in 2014. And since then we have, it's a FIT-based screening project with family physician, something similar to France, where family physician is the leading person. And I think it was putting into account of rather limited resources that we had at the beginning. I think the output is reasonable because we have about 23% of coverage up to now, and we have about 65% of colonoscopy uptake after positive FIT. But unfortunately, we realize that these are also significant. There has been some achievements, but they're not sufficient as we want to go forward. So this was clearly recognized a few years ago, and now we are in the process of redesigning our colorectal screening program, which the project is actually, the pilot project should start on the 1st of next year. And the plan is to go with a centralized invitation from two regional centers. They would kind of geographically split the country into two, and they would have centralized invitation with computer-based registration of all the steps within the project, and leaving family physician in for a visit before colonoscopy. I think that is, as a clinician, I think it is an important part to ensure safety of the procedure, and so that is how we're looking forward. In terms of finances that we see, we were lucky because we have allocated finances, and there was never a problem for any year. All the program was paid, and it's free in all the steps within the for the screen person.
Okay, thank you. Well, you've just given us a little bit of insight across different countries in Europe, and I'm now inviting you to start looking at the chat, because we've got a lot of input now that's coming in. And I'm going to start with a couple of questions that are addressed to Dominika, because they're interested in the Slovenia experience. We have a message from Titi from Finland, who asked, what proportion of people don't follow up on the first invitation, and a question from Iris, who says, well, they're surprised to see such high uptake even when you don't include the fit in the original invitation. And have you tested whether you get different uptake by providing it directly without having to go and get it? Because that's what some of the other countries have done. So let's start with those questions to Dominika, and then we'll bring in the rest of the panel. Dominika, you need to unmute.
Sorry. First answer to the Titi to Finland. Actually, when the person is for the first time included in the cancer screening, we see that approximately 50% of men doesn't respond, and approximately 30% of women. But average is 40% that we have non-responders to the program. The second answer to the Iris is when we started the program, we visited different countries, France, Finland, Italy. We collected different information how to organize, and we decided for the algorithm that we send out first invitation, and if the person decides to participate, they respond with the written letter. And after that, if the person has no exclusion criteria, only then we send test kit for the stool collection. Because we decided that it is too expensive to send out just immediately with the invitation also the test kits. And when we started, we had 50% response rate, and it would be too much money threw away. So we decided for this way, and now we didn't test it, what would be happened if we sent out directly also the test kits, but we see problems in other countries. Some have good responses, some not, but we decided to stay on our own way, and I think it is okay.
Okay, thank you. And now I'm going to ask the panel to pick up on a couple of questions around, cost effectiveness, etc. Because we've had a message from Isabel, who was on the previous panel, of course, say that it's important to evaluate the burden of colonoscopy. Could we prioritize screening, because over surveillance and inappropriate colonoscopies are about 50% or more of the activity? And we have another question to think about, which is how do you calculate the budget and the savings that you generate from early detection? I mean, Hajik, you talked about having to have a conversation with the Treasury, the Ministry of Finance, who in the post-COVID times will have very tight budgets. And if you had to make the case that screening saves costs as well as lives, how do you evaluate that? How can you make the cost savings clear? So panel, who wants to ask, or first of all, what about, if you have colonoscopy-based screening, you can have inappropriate levels of colonoscopy and it will be inaccurate. Shouldn't we push everyone to go to some of the screening, the feet tests? And secondly, how do you budget the savings that you get from running a screening program, so that the next time the Ministry of Finance says, well, we want to cut something, let's cut that screening, you've got really clear figures to show, no, it may cost you now, but it saves you money in the long term. So who wants to respond on the panel?
Let me tell you something to the topic quality of colonoscopy. We
Yes.
created in 2013 a European colonoscopy quality investigation group covering many countries, and to see how colonoscopy is performed in different European countries. And the quality criteria was taken by that, which was established by the European Society of Gastrological Endoscopy. And what we did see in the last years, the more you are adherent to the quality criteria, the better the colonoscopy process is going on. Therefore, this is, in my opinion, a very important measure to see, to get the standards in every European country on the same level. And this process has improved in the last years very much. I cannot say anything to the budget, because in Germany, the health insurance companies are paying all tests and colonoscopies, and therefore we have no national budget.
Thank you. Thomas, is there anything you want to share with us from Lithuania? When there's a discussion about, do we put the money into something like this, into screening? Are you able to make the case it's worth doing because you get X return on investment?
I cannot actually say that we have a problem with financing of screening services for some reason, and I don't know the reason exactly, but there is never a talk on screening program finance cuts, and that is what I'm happy about. I think we will be able to show we have data in process looking at the people at the survival of different of people who underwent different stages or underwent no screening, and I think there is plenty of data in the literature, but we will be able to show the better outcomes in people who are undergoing colorectal cancer screening. So I think since we have 10 years of surveillance now.
Okay, thank you. A couple more points that are coming in the chat. Again, a message from Italy also saying that we've got too many colonoscopies that are done inappropriately in surveillance and screening settings when they don't need to be done. So clearly there's some work to be done there, educating professionals on how to do it. But let me come back to this important point about you need to bring the population with you. They need to be informed and educated. And we've had some discussion about the difference between public awareness around the importance of screening and cancer and how the populations have responded differently under the pandemic. So how do we get everyone, keep educating new generations of people who reach the target age, who need to be aware of this, and make sure that you have that kind of public awareness and support. Dominica, you had these great campaigns. You had the side of the bus, the blue ribbons, the toilet paper. It looks to me like you're consistently feeding the public conversation. Members of the panel, how do you make sure that you've got the public engagement that will allow the political and financial support for the long-term investment in screening? You need public support. How did you do that?
Well, as I told you, in Germany, we have every year the March as a public awareness month. In this month, everything is focused on the topic colorectal cancer screening. It started with the government and is breaking down to local and regional activities like campaigns, like flyers, like talks, of physicians in regions. This is broken down, unfortunately, by the COVID pandemic, and now we are going to do video conferences, even including patients, informed to get the information done that they should not have any fear not to be infected in praxis or in clinics by the coronavirus, because these institutions are safe. So in my opinion, you should focus in 1 month on this topic. And from this month, many reactions are showing that the knowledge of colorectal cancer screening is very high in Germany. About 80 to 90% of the population know that there is colorectal cancer screening and the screening is effective. This is very much different from that what we have as participation rates. So we have to get to increase by invitation of different types, by letters, by onlines, by sending the tests to improve the situation. And I'm pretty much sure that we will succeed in the next years.
Thank you. Let me bring in Patrick from Ireland. What would you like to share with us?
Yeah, I think just to come back to how do you persuade the government and the funding agencies, and I think this is a central question. It's no good saying you're a really good doctor and patients like your service, because that doesn't really cut any ice. You have to say, in a competitive world where all these various specialties, cancer, non-cancer, transplant, are all vying for limited resources. Now, we did a health economics analysis before we start. And I think the health economists are important in this analysis because they have to say, using their quality of life estimates, what's the impact of a treatment, any given treatment? For high cost transplantation, for instance, what impact does it make? So our health economists have estimated that unless you make a 20% reduction in mortality, which is the hard outcome of all screening programs, that the health benefits, the cost benefit is not worth it. Now, I know that it was contentious in relation to the breast screening. Several publications in the last number of years have forensically examined the breast cancer long-term mortality. And some suggestion was that it was to do with a lead time bias and that there's questionable significant reduction in mortality. And this is contentious, but this is an area I think we need to get into from if there's going to be European funding, that we can say that over a 10-year period, a adequately resourced screening program achieving good compliance rates with good high quality colonoscopy, as Jürgen has said, will make an impact. And now economically, how do you translate that into the budget for the Minister for Health? Well, you'd say there's less colorectal cancer coming to the hospital, there's less chemotherapy, radiation services. And these are, and then as well as the economic benefits for the individuals in their 50s who are still within the working, within their working lives. These are the type of metrics that I think governments and funders need to see. And I think it's an important aspect, again, on a European-wide basis. It's something that there is health economics expertise throughout. And I think it's something, and if we can show that, then the publicity campaigns that have been alluded to, again, will be more successful, I think.
Yes, you make a good point there about the issues that ministries of health and finance care about, which is, the overall burden of a disease on their healthcare systems. And if the cancers are detected at a late stage, there's more chances that they would need some of these very expensive newer drugs that are coming on the market that are very, very expensive. So maybe that's another element to make. Now, I think if I could invite Iris Lansdorff-Vogelacher to come in, because I understand she's a health economist and might also be able to give us some insight in how you make the economic case for a sustained investment in population level screening with direct connection into follow-up, such as colonoscopies and then treatment. How do you make that case that that's worth doing? Especially as Patrick has just said, there's been some question. I know the same thing for prostate cancer screening. There's been some concern that we are over-treating or that there is marginal long-term impact on mortality. Iris.
Thank you very much. Quite unexpected, so I hope I can make something up as I speak. But in general, I think that we see that colorectal cancer screening, especially if you use a FIT-based screening program, the test itself and also the analysis are quite cheap. The big trend that we see with respect to the treatment of colorectal cancer is that it gets more and more expensive. The new chemo drugs, the chemotherapy drugs, they get more and more expensive and they gain very little. So there is some benefit to the patients, but it's often with a big impact on the quality of life, and the overall result is that there is on average a few months more of life. And so it means that if you screen and you, I think the big issue with colorectal cancer screening is, of course, that you cannot just prevent mortality, but you can even prevent morbidity, because you can actually prevent the disease. And so several studies, and especially the newer cost effectiveness studies, have shown that investing in screening now would cost you indeed some money now. Of course, it requires an investment, but in the long term, that money will be earned back from the fact that you prevent the very expensive treatment for the advanced colorectal cancers. And what we see over time is that this ratio of costs, investments versus the savings in the long term is improving. And I think that holds for many countries across the world, and not just for the high income settings anymore, because these drugs get more and more implemented in countries across Europe. So I think that's a very good case that we can make, that with such an intervention like colorectal cancer screening, we're not just saving lives, we're also saving money. That said, of course, that only is true if you make it a high quality investment. And so it is important to also think about a good organized high quality program.
Okay, thank you. We're coming towards the end of the time for this panel, and I have a couple of other comments from the chat I'd like to bring in. There's a question for Dominika, which from Thomas, who's saying, you know, how do you explain the sudden drop in colorectal cancer incidence immediately after the start of the program in Slovenia? And then presumably you wouldn't get a response to a population screening that fast. So there was an immediate drop, and it's a bit of a mystery. How did that happen? We've also had some conversation about, you know, colonoscopies, what quality they are, how high quality are, the expense of that, and where it should be, the link between that and screening, and that if you set up a screening program, you also should have a link to a high quality colonoscopy program. So let's start with Dominika, and then I'll ask all of our panelists to make a final comment. Dominika.
The reason that the incidence on the national level dropped immediately of the first screening round, we think that this is the reason in systematically removal of precancerous lesions, but really systematically. Everything what is found in colonoscopy must be removed and analyzed at pathology. We think that this is the main reason, and also the good response of people to the screening. And we also put a lot of effort to have a very good colonoscopist, because they are checked every 2 years. We organize meetings every year for them, show results, and we also gave them back results, meaning how many colonoscopy they done, what other rate is, what kind of lesions they found, and also what are the opinion of the patients about how the colonoscopy were performed. So there is a lot of information exchanging, and the quality of colonoscopy improved radically through the time.
Okay, thank you. Let me turn to other members of the panel for your last comments. Jürgen, what would be your final message?
Well, my final message is that we all should work together, that on a European level, we get an improvement in acceptance of colorectal cancer screening, stabilizing the FIT test and the colonoscopy, and giving the people the choice to choose between both.
Excellent, thank you. Okay, Pedrick, what's your last message you'd like to leave us with?
I'd agree that a pan-European approach will be helpful. I think as regards high-quality colonoscopy, the Rutter papers and the consensus emerging is that post-colonoscopy colorectal cancer is the single important metric that we can use as a quality measure, and the training continues. Again, having a European license in that area would be helpful to have a common standard, but I think that would be helpful, and also to be able to compare FIT programs across the European Union, so hopefully this will emerge with economic support across all countries.
Thank you. Thomas.
Thank you, and I think I agree with that we need European cooperation, we need European standards and interaction, but I also think that performing good screening is also very important in promoting it, because if we're doing it right, if we're doing it correctly, if we're doing without complications and effectively, that sends a message to the public that we're actually doing a good job, and then they're more involved.
Excellent. Well, a warm thank you to the members of our panels and speakers who have given us really good ideas